Right. Good afternoon. Today I am going to be presenting your NURN 110 Introduction to Pharmacology Week 3 lecture. So this week we're going to be continuing our discussion about dosage and medications, and we're going to be talking about parenteral dosage of drugs. So let's get started. So we talked a little bit last week about parenteral routes. So the route of administration, other than through our GI tract, is going to be that intramuscular injection, which is in our arm. We have our subcutaneous, let me back up, intramuscular. One of the ideal sites we use is our deltoid in our arm. We can also put it in some of our bigger muscles in our thighs. We have our subcutaneous, which is going to be in our fat. We have our intradermal, which is just under the skin. And then we have our intravenous, which is through an IV into our vein. So when we think about medications and the types of injections that we want to do, so if we're giving a type of intramuscular injection, we always want to think about the size of the patient for one, especially when we think about needle size. So we would never want to use a bigger needle on a patient who was very, very small, that didn't have a lot of fat. So we want to look at their size, and we also want to think about the amount of medication that we're putting into that muscle. So our smaller muscles, if we think about our deltoid, which is typically where we get a lot of our vaccines, so your COVID, your flu, your pneumonia, those sites are ideal for about 2 mLs, okay? If you have something that has more volume in it, 5, 6, 10 mLs, you might want to go into a bigger muscle like the vastus lateralis or something like that. Usually for an adult about 150 pounds, that maximum deltoid site is going to be good for about 2 mLs. If you think about a child 6 to 12 years old, we're thinking about 2 mLs again for that, for an intramuscular injection. And then childbirth to age 5, the capacity is about 1 mL. So just some things to keep in mind. And again, we're going to review about our 3-step approach to solving a dosage question. So we're going to continue to start working on these as the weeks go on. So the first thing we want to do in our 3-step approach is when we have a doctor's order that says, I want you to give X amount of medication, and what you have on hand is this amount of medication. The first thing that we want to do is convert. So we want to make sure that when we look at that doctor's order, that the medication that's ordered and the medication that we have on hand is all in the same system, right? So if the doctor's order says administer 750 micrograms of azithromycin, but what we have on hand is 700 or 7 grams for an example, we would have to convert and make sure that we put both of our medications in the same system. So both micrograms or both grams, whichever way we decided to convert. So we want to make sure that we're in the same unit of measurement first. That's our first step. Then we think, we kind of try to estimate a logical amount. Well, for some of you, if you're a little bit familiar with medications, this might be easy for you to do. For some people, not so much if you're not familiar with medications, but have no doubt this will change as you get more experience. And then the third step is we calculate. So this is our formula right here. We use our desired over what we have, and then times the quantity. So if there's any volume, if we have 750 micrograms to be given, and we have on hand 250 micrograms for every 2 ml. So then that 2 ml would go over here in the quantity. And this is going to make more sense when we start working out some problems. So then we're going to move on to our guidelines for syringe selection. So for standard doses more than 1 ml, we always use our rounding rule, okay? So when we figure out a dosage problem and our answer is in mLs, when we're thinking about volume, we always correlate volume with mL, so that's our liquid. Our 2 choices on our rounding rules are going to be to if we have an answer that's less than 1 ml or an answer that's more than 1 ml. If it's more than 1 ml, we're going to round to the 10th, and we're going to measure in a 3 ml syringe. A 3 ml syringe is going to be calibrated in 0.1 ml increments. So 1.53 is going to be rounded to 1.5. So in order to round to the 10th, which is where the 5 is, we have to look where the 3 is, which is the 100th place. And that 3 is less than 5, so we would keep that 5 the same, and we would have 1.5 ml. So we're going to talk about some high alert medications. So when we think about a high alert medication, this is a medication that has a high probability that it can cause significant injury to the patient if they don't get the right dose. So insulin is one of those high alert medications. So we use insulin to control blood sugar in patients that have diabetes. So usually insulin comes supplied as mLs, and it's by units. So insulin is 100 units for every ml. So every 1 ml that you have 100 units of insulin. It's abbreviated on the label as U-100. So we also have to make sure that we are using that orange syringe, which I showed you in class the other day, that is a U-100 syringe. So we should always think U-100 is 100 units for every ml, and then U-500 is going to be 500 units of insulin for every ml. Sometimes we have to combine insulin dosages. I was hoping to be able to show you this in class today, but since I'm recording, I cannot. So if you want me to, I can bring it to the next lecture and I can stay after and we can go over this. So sometimes we combine short-acting, long-acting insulin together, which is exactly what we've done in this syringe right here. So if you can see the different colorations through this barrel here, we have 40 units of our NPH insulin. So if you see right here, it fills all the way up to the 40. And then we also drew up 12 units of regular insulin. So from the 40 to the 52 is our 12. So we have a total of 52 units, 40 units for NPH, 12 units for regular. We can combine insulins in a syringe, but we have to be very particular how we draw them up. So let's talk about that. So whenever we pull anything out of a multi-use vial or even a single-use vial, however much we're pulling out, say we know we're going to administer 10 cc's of, or 10 ml, sorry, of a medication. We would want to pull back on our empty syringe to that exact same spot on the syringe, 10 mLs, and then we put our needle inside the top of the bottle like you see here, and we inject air, okay? We inject air into the bottle, and then we'll flip the bottle upside down, and it'll help us to be able to draw our medication in. So it creates some pressure in there to make the medication come out easier. So step one here, we're going to pretend like we're giving 40 units of insulin. So we're going to take our empty syringe, pull it back to the 40 mark for 40 units. Then we're going to take the cap off, clean off the top of our bottle there, inject our needle in, push down on that barrel, and inject that 40 units of air into the bottle. Then we will turn that bottle upside down with our non-dominant hand, and we will withdraw whatever it is we're going to withdraw. So in this case, we were drawing up our regular insulin first. So withdraw 12 units of insulin. And then we're going to move into our next bottle and withdraw 40 units of NPH for a total of 52 units. So let's go back here. I want to talk to you about this again. I just wanted to kind of give you an overall of what we're going to do, kind of so you understand that process, and then we're going to go a little bit deeper. So when I said a couple of slides back that when we withdraw two different types of insulin, in particular an NPH and a regular. NPH is a cloudy insulin. Regular insulin is a clear insulin. So whenever we're combining doses of NPH and regular, we always want to draw up the regular insulin first, okay? So if we know that, we have to be a little strategic about how we inject our air into the bottle. So since we're going to draw up the regular first, that means that we're going to inject air into the NPH first. Okay, we're giving 40 units of NPH. That's our cloudy. We're going to inject our 40 units of there, then leave that bottle. Then we're going to go over to our regular, and we're going to give 12 units of regular insulin. So we're going to inject our 12 units of regular insulin. Since we want to pull that up first, we're going to leave that syringe in that bottle, turn that bottle upside down with our non-dominant hand and pull back 12 units. Then we're going to go over and pull up our 40 units. Now we've already injected air in there, so we don't have to do that again. And now we can put our syringe in and pull back our 40. So we never want to, the purpose for doing this is we never want our cloudy insulin to get in our regular insulin. So that's why we want to pull up our regular first. We don't want to contaminate what's in this bottle. So we never want our cloudy to go inside of our regular bottle. So we always pull up our regular first, and then we go over and we withdraw our cloudy. So clear and then cloudy. All right, so how do we administer insulin? So insulin goes on what we call a sliding scale. And usually the doctor will decide when we want to administer their insulin. Sometimes it's at night, sometimes it's before meals, breakfast, lunch, and dinner, and at night. It depends on what the doctor orders. But let's just have the scenario that we check a blood sugar on Mrs. Jones. Her blood sugar is 162. Which we know is elevated. A normal reading is between 7 and 100. The doctor has orders in for insulin. So how much insulin do we give her based on a blood sugar of 162? So this is what it would look like in the MAR. This is our sliding scale. So over here is the amount of insulin that we will give. Over here is our readings, our blood glucose readings that will determine how much we will give. And then we kind of have some parameters down here. So we know her blood sugar was 162, so let's look on the chart. 160 to 220, we're going to give 2 units. So we're going to give her 2 units of insulin. We have these parameters down here. If that blood sugar would have been greater than 400, we're going to hold the insulin and call the doctor right away because he might want to put a special one-time dose in to give her a little bit more insulin. So this is our sliding scale, pretty straightforward. So we want to be very careful when we're handling insulin. This is a high alert medication. If we gave somebody too much insulin and we dropped their blood sugar too low, it could be very dangerous for the patient. So usually in a lot of facilities, you have to check this dose with another nurse. Some facilities do not require this. They do require it where I work. So I figure out how much insulin I'm going to give. I pull it up and then I go grab another nurse and I say, hi, can you co-sign my insulin? I have 2 units of insulin here for Mrs. Jones. She's in room 4526. Her most recent blood sugar was 162. I make sure that I docked my machine so that all these values upload into the MAR. I show her the 162. I show her the patient's vial with the patient's name and information on it. And I show her my insulin that I have pulled up, and then she co-signs. When there's a combination dose that's going to be prepared, like we saw earlier, you would have to actually pull that up in front of the nurse so that they would be able to verify that process, because they can't really verify that process once I have it pulled up and they can't see if I made any mistakes. So just something to remember. So now we're going to move on to reconstitution of solutions. So the first part of thinking about reconstituting something is to understand what the actual parts of a solution are. So we have 3 parts of a solution, well, 2 actually. So we have the solute. The solute is going to be that concentrated substance. Then we have a solvent. Our solvent in this case here is water, and a lot of times it's water. You mix the solute, which is the concentrated liquid or the powder, whatever you have, and the water together, and that gives you your solution. Okay, so it becomes your solute becomes diluted because you're adding the water, and then you have this reconstituted solution that is now ready for preparation. So when we mix and dilute solutions, that solute, again, is that substance that's going to be dissolved or diluted. And like I said, it can be a liquid or it can be a solid. A lot of times in the healthcare field, it's a powder. We have our solvent, which is that substance, that liquid that dissolves that other substance to prepare a solution. And a lot of times it is that water. And then that solution is that resulting mixture that we get from taking that solvent and that solute and combining them. So before we reconstitute any type of an injectable drug, it is up to us as nurses to read and follow that label or whatever that pack that we're following the instructions. So we're going to check the drug, and we're going to check the drug and the dilutant dates and make sure that everything is correct and is not expired. So we're going to determine both the type and the amount of the dilute that's going to be used. We're going to determine the volume in mLs of the dilutant that we need to use for the route as ordered, and then we will reconstitute that drug and not the resulting supply dosage on the vial. So we have to follow the instructions. So here's a good example. We have Zithromax solute in, which is 500 milligrams in this container, okay? Our solvent or our diluent is our 4.8 sterile, 4.8 mLs of sterile water. When we add this water together, it's going to give us 5 mLs. And a lot of people may say, well, you only put 4.8 mLs in. How are you getting 5 mLs? Well, this powder actually takes up spot. So we say that's about 2 mLs. So once we add the 4.8 of water to this and we shake it up and we dilute everything and get it all mixed, then we end up with this 5 mLs. So let's talk about this for a second. In this first jar right here at the very bottom, we have this powder. That is the equivalent of 500 milligrams of Zithromax, okay? We're going to add 4.8 mLs of water. Now we have a lot of volume here. So it'll tell you on the label that for every ml that you have now, you have 100 milligrams, okay, per ml. So if you needed 200 milligrams to administer, you would pull up 2 mLs, okay? If you needed 250 mLs to administer, you would pull up 2.5 mLs. And the more you get familiar with this, the more it will make sense. So this is your reconstitution label that you would put on your label when you were done. Okay, so you put the expiration date, the time, what you reconstituted it as, the date and the time you reconstituted it, and your initials. And if it has to go in the refrigerator, then it would also go in there. Sometimes these already come pre-printed from the pharmacist. All right, so this is a parenteral solution reconstitution procedure. So with this procedure, we are drawing up Kefazole, okay? So we are going to inject 2 mLs of air into our sterile water fluid because we need to pull back water. So we're going to put, however much we want to pull back, we're going to put that much air in. So we're going to put 2 mLs of air in. Then we're going to turn that bottle of sterile water upside down, pull out 2 mLs of sterile water. Then we're going to inject it into our next bottle, which has Kefazole, 500 milligrams of powder. We put that in, we mix it all up. And then now we know we have 2 mLs of 500 milligrams. Okay, so we have 500 milligrams now diluted in 2 mLs of water. So if we wanted to administer 250 milligrams, we would give 1 ml because 250 is half of 500. If we wanted to give the whole 500, we would pull back 2 mLs. So remember, always label your reconstituted multi-dose medication with the date and the time of preparation, the supply dosage that was prepared, the length of potency, any type of storage instructions, directions, and your initials. All right, so when we talk about the solution strength, so the solution strength is a fraction that expresses the strength of a solution made from a liquid concentrate. Okay, so this is the amount of drug that we have. So the numerator is going to be, the numerator is the number of parts of a solute. Your denominator will always be the number of parts of the solution. And the difference between the denominator and the numerator is going to be the number of parts of a solvent. So, for example, we have 1/3 strength nutritional formula. 1 part concentrate, so it's very, very concentrated. So it means we have to add something to it to get the appropriate dose. 3 parts of a total solution. So we have a 3-to-1 ratio. 3-to-1 minus 3 minus 1 is going to be 2 parts solvent, which means water. Okay, so we would add 2 parts water to make this 3 parts total solution. All right, so whenever we're doing a solution calculation, this is the formula we will use. So we apply this formula to find the amount. So it's our desired solution strength times our quantity. So our desired solution strength times the amount of desired solution that we would like. That's going to equal our amount of solute. So you would use this calculation. Okay, so the amount of the quantity of the desired solution is the amount of the liquid solute, which equals the amount of the solvent. All right, so next we're going to move on and talk about pediatric and adult dosages based on body weight. So for just kind of a little refresher, so I know we're all really familiar with doing things in pounds and ounces, but in the nursing world, we do everything in kilograms, all of our body weights. So 1 kilogram is the equivalent of 2.2 pounds. Okay, so whenever you want to figure out what a weight is in pounds, you would divide that weight by 2.2 pounds. So if I say my patient weighs 100 pounds, I would divide that by 2.2 pounds to get the weight in kilograms. Okay, whenever you're converting pounds to kilograms, you always round your kilogram weight 1 decimal point to the 10th. So whenever we want to verify a safe pediatric dosage, we always want to convert our child's weight from pounds to kilograms because that's what we work in. And then we want to calculate that safe weight in milligrams per kilograms or micrograms per kilograms. We compare the ordered dosage to the recommended dose and decide if it's a safe dose. If it's a safe dose, we calculate the amount to give and we administer the dose. If it seems unsafe, we will always contact the ordering practitioner for clarification. And we'll do some of these in class to practice. So once an adolescent gets to a weight of 110 pounds or 50 kilograms or greater, then we start applying the standard adult dosage to what medications we prescribe. So even if they're 10 years old, if they weigh 110 pounds or greater, we're going to dose them as an adult. We should always verify that the order for the child's dosage does not exceed the maximum. We have to be very, very careful with children and older adults. So, quick review. To use the body weight method to verify the safety of pediatric and adult doses, we convert our body weight from pounds and ounces to kilograms. Okay, calculate the recommended safe dose and then compare the ordered dose with the recommended dose to see if it is safe. So if the dosage is not safe, if the dosage is safe, calculate the amount to give for 1 dose. If not, notify the prescriber. Combination drugs are ordered by dose volume. So we check a reputable drug reference to be sure that the dose ordered contains the recommended safe amount. So we're going to be going to our drug book or whatever we have on hand at the hospital. All right, so now we're going to dig a little bit deeper. We're going to talk about intravenous solutions, equipment, and some calculations. So some of our patients in the hospital setting, we frequently give them IV fluids for a number of reasons, and you're going to learn all about those different reasons. A lot of times we give it to them because they're dehydrated and we need to replace something. So there's a variety of different solutions that we can give. They have different concentrations to them, and it depends on what their problem is versus which solution we're going to choose for them. So these are some common solutions and their abbreviations. So D is for dextrose, W is for water, S is for saline, NS is normal saline, NaCl is sodium chloride, RL is Ringer's lactate, LR is lactated Ringer. So you want to commit these to memory. So remember I told you about the different types of fluids. They have different concentrations. So we can give a hypotonic solution, an isotonic solution, or a hypertonic solution. So a hypotonic solution is going to be used to dilute excess serum electrolytes. So when our blood is going to be too concentrated, so we don't have enough water, but we have a lot of particles. So we're going to give a hypotonic solution that has a lot of water in it, less particles, and it'll kind of restore some of that volume. We like to give 0.5% saline, okay? Half normal saline, we call that. Sometimes we give an isotonic solution, which is just used to expand volume, and it maintains a normal tonicity or a concentration. So it's not going to change the concentration of our blood in either direction. So that's our 0.9% normal saline, our lactated Ringers, and our 5% dextrose. Then sometimes we have to give a hypertonic solution, and this is also going to be used to correct electrolyte imbalances. So this would be when we have too much water, not enough particles. So hypertonic solutions are heavily concentrated. They have a lot of particles. So an example of this would be 5% dextrose and 0.9% saline, or 5% dextrose and lactated Ringers together. So when we think about the different sites on the body where we can administer IV fluids, so we can always do a peripheral infusion, which is in our arm, in our hand. The rate of infusion in any type of a peripheral site should never exceed 200 mLs in 1 hour. So this is how quickly the fluid's going, because these veins aren't really large enough to hold large volumes of fluid going in at one time. If we have to give something that's very concentrated or something that's very hard on the veins, like a chemo or high amounts of fluid, we would want to administer those fluids in a central line. So central lines, you're going to learn more about them. They're lines that go into bigger veins inside the body. A lot of times they sit in the chest, and the tip of the lines will end up in the heart. Those lines, we call them central lines, can accommodate larger concentrations and larger volumes of fluids. So we always have to worry that when we are taking care of a patient and they have an IV site, we're responsible for maintaining that site and making sure that everything is fine and that it's complication-free. So every shift, we're going to be flushing that IV site, making sure that there's no redness around the site, there's no swelling, there's no warmth or redness, which could indicate an infection, that it's not swollen or cool, which could indicate some type of an infiltration. So some of the complications we can see are phlebitis, which is a redness, and infiltration, where the fluid is still going into the arm, but it's not going into the vein, and it starts going into that surrounding tissue. And then also an infection, so redness, swelling, purulent discharge. So when we think about giving an IV, sometimes this is a great example of how we can give it. So sometimes we give IVs in, they're hooked up to a machine. We call it an infusion pump, and we can calculate the rate that we get it. Sometimes we let them hang by gravity, which is what you see here in the picture. So we have our 1 liter bag right there, or some type of solution. We spike the bag with our tubing right there, which you see hanging. So we take our drip chamber and we would inject it into that injection port at the end of the bag. We would prime our tubing. You're going to learn how to do that in lab. And then we could control the amount of drips that come out of that container with this roller clamp right here. So we would push that little roller up, and it would up and down, and it would completely lock the tube so that nothing comes out, or we could open it wide up and fluid could come through very, very quickly, or we could have it somewhere in the middle and actually control how many drips we have coming out of there. Sometimes we have to hang another type of a fluid in addition to our primary fluids. So your primary fluids would be what you see on the left-hand side there, that's going into your regular IV. But sometimes the doctor says, okay, Mrs. Jones has the UTI, so I want her to have normal saline at 100 mLs every hour, but I also want you to give her this IV cefazolin for her UTI. So now we have to go in and hang this IV piggyback, this littler bag here of this antibiotics. And this will be primed and set up the same way as our primary bag, but then we're going to connect this IV piggyback into the tubing right here, and then we can set it up so that they both go in together, or we can set it up so that we stop these primary fluids and just our IV fluids will go in. And then when our IV fluids are done, our primary fluids will start again. And again, you're going to talk about all that in lab. So what is the IV flow rate? So how do we know how fast we want fluids and antibiotics, potassiums, and things like that to run? So these are always going to be ordered by the physician. Whoops, sorry guys. Always going to be ordered by the physician, but it is our responsibility to regulate, monitor, and maintain that flow rate. It's also our responsibility to determine, not all patients always have to have fluids. So maybe a patient came in and they were nauseated and they were vomiting and they weren't tolerating any food or liquid, so they had fluids, but then, things resolved and they're tolerating a diet, but it's been 2 days and they're eating and drinking, but the physician forgot to cancel those fluids. It's your responsibility to say, hey, I don't think this patient really needs fluids anymore. Let me talk to the doctor and find out the reasoning why we still have these fluids going. It's your responsibility to make sure it's going at the right the right ordered amount, make sure that that IV is not infiltrating, that there's no phlebitis, that there's no infection, that it's not leaking. And then it's also up to you to kind of make sure that that is a good rate for your patient. So sometimes we might have a patient that has congestive heart failure. Patients that have congestive heart failure, we have to be very careful with the amount of fluid we give them. So maybe you have an order that comes through for fluids at 200 mLs per hour, but this patient has heart failure. So it might be something that you might want to check with the doctor for first and make sure that he's aware she has CHF, and then make sure it's something that he wants to still administer. So this is the conversion that we will use for our IV flow rates for mLs per hour. So we're going to regulate an IV volume by electronic infusion pump. So it's going to go through a pump or a calibrated controller in an ml per hour fashion. So to do that, we would use this formula. So we would take the total mLs that are ordered by the doctor, and then we would put the total hours ordered, and that would give us our infusion amount per hour. So the doctor orders 1,000 mLs of normal saline over 24 hours. So 1,000 divided by 24 would be, figure it out, 1,000 divided by 24 equals 41.66666. Our rounding rules say that we round to the nearest whole number. So if we have 41.6, we're going to change that one spot because that's our whole number. So our 6 in our 10th spot is greater than 5, so we would make that 1 a 2. So we would have 42 mLs per hour. Sometimes we have to figure out what our IV flow rate is in drops per minute. So remember that first picture we went back to where the IV fluids were hanging kind of to gravity and they weren't hooked up to the machine? This is the formula that we would use to calculate drops per minute, okay? So we would use our volume, so whatever the volume is ordered. So our volume is going to go at the top, our time in minutes. So your volume always has to be in mL. If it's not, you have to convert it. Your time always has to be in minutes. So if it's not in minutes, you have to convert it. So if I say I want the patient to have 500 mLs in 2 hours, you would have to put 500 over 120 because there's 60 minutes in an hour. And that formula, we have to use minutes. And then the problem will always give us our drop factor. So we would put our drop factor there and then we would solve. And we'll work some of these out in class. So we would take our volume, which is the V, times the C, our drops, okay, and get that answer. Then bring over our time and then divide, and that would give us our answer. For IV flow rate problems, we always carry our calculations to 1 decimal point. We round our drops per minute to the nearest whole drop, because it's kind of impossible to calculate half of a drop. So we only calculate whole drops. So these are just an example of the drop factors that we have in our drop factor constants. So 10 drops per ml is 6, 15 drops per ml is 4, 20 drops for every ml is 3, and 60 drops per ml is 1. So there is an IV flow rate shortcut method. You can always do the mLs per hour over the drop factor constant, if you know that. That'll give you your GTT per minute. But most students really like to do this drop per minute right here. This is usually the one we like to do. All right, so sometimes we have to adjust our IV flow rate, okay? So adjusting the IV flow rate, we always want to check for our institutional policy regarding correcting off-schedule IV rates and the percentage of variation allowed. So in most places, that variation of fluid should not exceed 25%, okay? So sometimes we might have a patient who is not tolerating something, which is what I see in most cases, is not tolerating a fluid because it burns or it's going too fast and the IV keeps beeping and we don't want to blow the vein and have to put in a new IV. So instead of running it at 50 mLs per hour like it was ordered, we might want to adjust it and make it a little bit slower for the remainder time. So we have to kind of adjust this IV flow rate, figure out the adjustment, and then figure out, make sure it's not more than 25% difference. So how do we do that? We use the following formula to relocate the ml, to recalculate the mLs per hour or the drops per minute of the time remaining and the percentage variation. So we would take our remaining volume and our remaining hours and divide it. So we have 500 mLs left to go in, and we're only going to put it in over 4 hours. We get that ml, and then we would calculate over, and that would give us our variation. Okay? We don't do a lot of this in nursing. If we do, we talk to the doctor about it, and we kind of agree on a volume together. So the percentage of variation will always be positive if the administration is slow and the rate has to be increased. So if we're increasing the fluid for some reason to make it go in faster, it's going to be positive. The variation will be negative if the administration is too fast and the rate has to be decreased. Okay? So whenever we're calculating infusion time, so how long is it going to take to go in? So to calculate infusion time, when our mLs, however much volume we know, so 500 mLs, we use this ratio proportion. So you take your total volume over the amount of mLs that's going per hour. So we would do this sometimes if we want to say, okay, I just came on shift at 7. My patient has 400. I want to know when I'm going to have to come back and change this patient's bag. His bag's less than half full, his IV fluids. And he's getting continuous fluid. So I want to make sure I get back there before that bag runs out. This is the formula I'm going to use. So right now I look at the patient's bag. He has about 300 cc's left, or mLs left in the bag. The infusion is going at 150 mLs per hour. So I would put my total volume at the top, the 300, how fast it's going, the mLs per hour at the bottom. So in this case, 300 divided by 150, I would divide, and that's 2 hours. So I know in 2 hours that bag's going to run out and I have to go back and change and put a new bag in. To calculate the IV infusion time, the flow rate in drops per minute, when the drop factor and the volume are known, we're going to use this ratio proportion. So it's your mLs over your hours, okay, over your total mLs, and then the X is total hours. So the T is what's unknown. So you would use this formula: volume in mLs over time in minutes times your constant, your drop rate equals your rate. Oops. Did I go back? I did. Sorry. All right, so flow rate and drops per minute. This is when your drop factor and volume are known. So your volume in mLs over your time in minutes times your drop rate equals your rate. And this time the V is unknown. This is your volume, okay? So we will be using these formulas throughout the semester, calculating dosage problems. So now we're going to talk about advanced adult intravenous calculations. So to administer critical intravenous medications according to the protocol, we follow 3 sequential actions. So sometimes we have to give a bolus. So we have to determine the need for the bolus dose. So large dose to rapidly achieve a therapeutic effect. So that is basically what a bolus is. So instead of giving, let's say a patient's blood pressure is a little low, we want to bring up that blood pressure by giving it fluids. You know, if their blood pressure is 110/70, we might want to give fluids at, I don't know, 100 cc's per hour. But sometimes if that blood pressure is critically low, like 60/40, then we want to achieve that increase in blood pressure pretty quickly. So we give them what's called a bolus, which is a very fast amount of fluid quickly, because we want to achieve that a therapeutic effect very quickly. So we want to make sure that it's appropriate for our patient and that patient condition, okay? So we select the right supplied drug, we calculate, and we administer the right amount by either IV push, if you're an RN, or direct IV infusion, okay? So a bolus, we can set the rate to go very high and it can go in through an infusion pump, or we can just open that tubing wide up and it can just go very quickly into the patient. Sometimes we can do a continuous infusion. So this is to acquire the right concentration of the continuous solution from the pharmacy. Or you can mix the IV piggyback bag by selecting the right supplied drug. So we can hang a primary fluid at a certain controlled rate, and then we can also select a certain antibiotic to administer at a certain controlled rate via a continuous infusion. And I will bring these IV pumps in and we will talk about that at our next lecture. So the rule is to calculate to determine the amount required to provide the order and set the flow rate. Sometimes we need to rebolus or adjust an infusion rate. So this is always going to be based on us monitoring the patient of some sort and being in contact with the doctor. So we're going to determine, does the patient now need an additional bolus, or if the continuous rate needs to be increased, decreased, or discontinued. So if we use the example of the patient that had low blood pressure, we gave him a liter bolus of normal saline. I rechecked his blood pressure. His blood pressure is 80/50. The doctor's a little satisfied with that and says, okay, we don't want to give him too much fluid. Let's now put him on a continuous infusion at 100 mLs per hour, okay? So we could have either rebolused if the blood pressure were still low, or if he decided to have that, or we could have just, you know, continued with a primary infusion. All right, so now we're going to talk about heparin drips. So sometimes patients that have an issue with their blood clotting, so patients that developed a blood clot, we have to give them a dose of heparin through a continuous infusion to keep their blood at a certain viscosity so that it doesn't clot too quick, but doesn't clot too slow and cause a blood clot. So we always determine our heparin dosages based upon the weight of the patient. So having a weight, an accurate weight in real time, is a necessity. When we have if we take this number 2 here, I'm going to repeat this. I'm going to read this for you guys. Heparin, 25,000 units in 250 mLs of half normal saline. Bolus is to be given as 1,000 units. So let's talk about this first part. Heparin, 25,000 units in 250 mLs of half normal saline. I know some of you guys are like, what is she talking about? So let me explain. So let's think about that IV piggyback bag that we showed just last week in class, okay? Imagine that bag being a little bit bigger, and it has 250 mLs of normal saline in it, okay? It doesn't have anything else in it. It's just normal saline, but the volume that we have is 250 mLs inside that bag. So what pharmacy does is we don't usually just put medicine in a bag by itself. We always mix it with fluid. So with heparin, we mix in normal saline, or half normal in this case. So they took that bag, that 250 ml bag of half normal saline, out of the stockroom, and then they took 25,000 units of insulin, they drew it up, and they injected it into the bag. Now the patient is going to receive an infusion of this bag of 250 mLs that now has 25,000 units of insulin in it. So that's exactly what that means. Then what we do is if a patient's on a heparin drip, we start off with a certain particular dose. They're going to get so many units per hour. Every 6 hours, we're going to redraw some labs, usually their APTT. If their APTT is not in a therapeutic range, so we look at heparin ranges kind of like we do sliding scale. There's a certain number that we want them to be in between, which tells us that they're therapeutic. If they're therapeutic, that means that their blood is the right consistency. It's not too thick, it's not too thin. They're not going to get a blood clot. That's what we want to achieve for these patients on heparin. So we're going to look at these APTTs every 6 hours until the patient has therapeutic results twice. Okay, so every 6 hours, if that APTT comes back and it's still low, it's not close to that therapeutic range, we might have to rebolus, kind of like what we talked about a couple slides ago. So when we do that, we give that in 1,000 units per ml. They might get 5,000 units. If they got 5,000 units, they'd get 5 mLs. If they got 2,000 units, they'd get 2 mLs. So normally what I see in my practice is we get half boluses and regular boluses. Regular boluses are usually 5,000 units. Half boluses are 2,500 units. So a half of an ml or a whole ml. But again, you're going to follow your hospital policy. So when I started nursing, we used to have these protocol worksheets. Everything was on paper. We don't do that anymore. Everything is in the computer. But this tells us the initial bolus that we gave, what rate it's infusing at. And then every time we check that APTT, we would put the date, the time, what that APTT came back at, and what did we do? Did we change the rate? Did we give a bolus? Do we have a new rate? And then 2 nurses have to sign off. So this is also a high alert medication. We don't want to thin a person's blood too much. If we make a mistake, they could bleed to death. Okay. So here is an example of this sliding scale type of a thing that you would see in the computer. So if the APTT came back 45 to 75 seconds, we would say that they're therapeutic, right? So the rate came back at 65. Okay, they're therapeutic. We're not going to make any changes. We're going to continue with this rate. If it came back 37, then we would have to rebolus with 40 units and increase the rate by 2. Okay, so this is your heparin. So to calculate the heparin bolus, we calculate the dosage of units of the heparin based upon the patient's weight. So for example, 5 units for every kilogram of weight. Calculate the volume, the mLs of the bolus to prepare using the dosage calculation formula. So this is the formula that we always use for heparin. So that desired is the order that they set for the patient, right? I want them to receive 1,150 units of heparin. That's going to be our D. Our have is always going to be that 25,000 that's in the bag, okay? And then our quantity is going to be the size of that bag. And in our previous problem, it was 250. And we'll work some of these as well, and these will definitely make more sense to you. So this is it for week 3. I know this sounds like a lot. Try not to panic. We're going to start working these problems. You're going to start correlating things in lab. Things are going to start making sense. You guys got this. You're going to get through this. I know it seems like a lot. If you have any questions, send me an email and I will get back to you as soon as possible. I hope you guys have a fabulous weekend, and I'll see you in a week from Tuesday. Have a good day.